Okay, all right, so let's get started. Well, thanks everyone for joining us today and welcome to our third session of our community of practice on the role of health centers to provide primary care for justice-involved individuals. In today's session, we will be focusing on improving continuity of care during the 30-day post-release period. As a reminder that our participants are muted upon entry. Please also make sure that you engage in the chat. If you have any questions, you may also raise a virtual hand if you would like your line to be unmuted as well. So today's session is meant to be a very engaging session where we're going to be asking some questions to the audience. So we highly encourage you to participate in the chat or verbally as well. This meeting is also being recorded, and the slides in the recording link will be sent via email after today's session. And for those of you that may be joining us for the first time, the mission of NCHPH is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by HRSA and do not necessarily represent the official views of the U.S. government. So for today, we have our wonderful speaker, Dr. Kevin Lombardi. He's our Director of Research, Policy, and Health Promotion. And if you would like to learn more about his background, all the information will be provided to you in the slide. And just a brief introduction about ourselves. My name is Fide Pineda Sandoval, and I am the TTA Manager here at NCHPH. And with me in the line, I also have Olajumoke Oladipo. She is our Health Communications and Health Research Analyst. And now, without further ado, I'll pass it on to Dr. Kevin Lombardi to get us started with the session.
Okay, my turn. Okay, great. This will be a participatory session, guys. Like we've been doing. Today we're gonna follow Mr. Stevenson through a different part of the post-release period, specifically that 7-day window. And follow him through the rest of the 30-day release period. This is on purpose. The 30-day release period is among the most dangerous times you can be in America in anyone's shoes. Um, Risk of mortality, morbidity are many times the general population. And it's really a epidemiological minefield for folks after release, particularly for those who have been in long sentences, for those who have chronic diseases, and for addiction and behavioral health issues. That ratchets up the severity with everything and is its own factor as well. So for our individuals who are justice involved post-release, they are often dealing with a ball of yarn of different fast-moving dynamics, including their own health. Their health is a big part of it. So we're going to talk about how we can provide stability there and how it provides stability everywhere. Next slide, please. Okay, here's what we're going to sort of poke our fingers at. Describe the key failure points in the post-release care. There's a lot of them. They range from one, not knowing someone's justice involved, to two, not providing the resources when they're needed. And they end up with a what can seem like just like a silent result. The patient just doesn't show up. You never see them again, and they are lost to care. What happens to them in the community? One, they are still your patient. They are associated with your health center. Um, they still affect value-based care dynamics. Three, their lives continue in the community and don't just affect them, affect all the people around them. There are consequences in medicine that are often very silent. You just don't see it, but you know they happen. Being able to visualize them and see them, understanding these stories, it gives you a better understanding of what really the environment is for people out there. And if you understand the lives outside the clinic room, you're going to understand them better inside the clinic room and what your role is, how you provide that support. Two, define an operationalized closed loop follow-up model. And this model is find out in the beginning, link to care, coordinate closely, with some details, of course. Identify the strategies for improving retention and opioid use disorder treatment in particular, given the life or death nature of OUD at any time, but in particular during the post-release period. OUDB is sort of a baseline danger for a patient. It's a risk that I'm almost thinking of like college chemistry, how enzymes work, energy catalysis, and so forth. If you have a history of OUD, a history of relapse, any volatility in your life is going to affect that system. And for justice involved individuals, it's not just the post-release period, it continues afterwards. The more stability you can introduce earlier, the more stable the system of their life is, the less volatility that they experience, the less likelihood they're going to have relapse. This is a chemical level thing. And I'll sort of get into this a little more as we go into more with Mr. Stevenson. And of course, taking an interdisciplinary perspective. No one takes care of a patient by themselves anymore, and that has not happened for a very long time. We're all a team. Unfortunately, it's not like a soccer game where we can all look on the field and kind of see where Mary is and see where Joe is. The case manager, the physician, the triage nurse, we're all on the same team and we're all throwing the ball, but we often do not see each other. Sometimes the most directly we'll see each other is a note. But finding those areas of communication, those strings that we can pull on, and work as a more of a cohesive group, it's going to make your patients, especially those like Mr. Stevenson, have better outcomes. It's going to make you have a lot more fun at work too. So we will pull on those threads as we can find them. Next slide, please. Let's do just a refresher on Mr. Stevenson and sort of how we are using him to elucidate the epidemiological environment that is the post-release minefield. And I saw you put your camera off, Fide. That doesn't stop me from picking on you. Um, so, Mr. Stevenson, there goes. Gotcha, gotcha. Yeah, that makes me want to do it. Okay, I'm just teasing.
There's
Uh,
no escaping.
Let's review. Let's review. Mr. Stevenson's a 41-year-old male. He's recently seen in his health center after a 3-year sentence in a state correctional facility. Not a terribly long sentence, but enough where systems have changed significantly when he's gone back. I remember once I met a patient who had been in for 25 years and he didn't know how to use an email. And when he was released, the technology was a major destabilizing factor in his life. He didn't know how to use these systems. He hadn't been using email. He hadn't been using a phone. And it was like moving to another country was the acclimation. 3-year sentence, it's enough for a lot of things to change. His medical history is significant for hypertension, type 2 diabetes, a long-standing history of OUD. And remember, we've got 3 PATS overdoses, one in 2021 and two in 2023. He said he didn't use opioids in prison. So we don't know. At his PCP appointment, which we saw him last session, he was noted to be hypertensive. 168 over 82 is worth batting an eye over, in particular given his history and the fact that he hadn't taken his medications for 5 days. He also noted symptoms of fatigue, depression, and increasing cravings to use opioids. So, a really scary basket of symptoms here. And he may be standing in front of us fine right now, but this is someone who is at risk. At risk. Next slide, please. One minute. Okay. Um, anyway, um, uh, he reestablished care at our health center last visit, and was treated with the buprenorphine 8 milligrams. Started at 4, we titrated up to 8, standard treatment, with resolution of symptoms observed in the office. He was provided with a naloxone kit and overdose prevention education in the office that day, too. In addition, we provided him with 7 days worth of medications and assignment to a community health worker for coordination and support. We also referred him to OUD treatment. He was scheduled for a follow-up in 7 days. And that 7 days was on purpose because of the coordination here is incredibly detailed, and the medication follow-up for the chronic disease required a blood pressure check and a check on symptoms. So we decided 7 days. With justice involved individuals that are going through coordination evolutions, they're getting their insurance, they're restarting care. They are starting care for some things like the opioid use disorder with Mr. Stevenson. Uh, Assign the appointment sooner rather than later. Those changes are going to need close follow-up. And when you have a patient that's starting new medication or restarting medication for a chronic disease when it hasn't been taken, and they're also experiencing volatility, not just justice involvement, but if they're involving life volatility in some way, always go earlier rather than later. So we chose 7 days. Um, so some things to sort of pull out here is don't sleep on the naloxone kit and the overdose prevention education. I remember back in the old days when the opioid uh, epidemic was new news. And it was difficult to get naloxone. There were shortages of it sometimes. It wasn't as publicly available. Now, thanks to state, local, federal programs, it's comparatively much more available than it was 10, 15 years ago. I will say, though, that that's still a work in progress. The more niches you can put naloxone and you can put the education that goes with it, the more likely you are to save someone's life, to prevent something bad from happening, to promote safety. It's like putting actual guardrails up on the highway. It's sort of like an image of how you can think of that. Uh, with patients like Mr. Stevenson, sometimes there is the assumption that someone else is going to do this. The naloxone kit, oh, the nurse will do it. The doctor will do it in the office. The social worker is going to do that. Social worker does that. Yeah. No, the community health worker is going to do that. Everyone should address this. Everyone should check this because this is one of those things that you don't want to miss. And it's one of those public health moves that is the data is so supportive of making naloxone available that we want to prioritize that as much as possible. So, health centers are innovators in this space, and I know to a certain extent, I'm preaching to the choir here. That is not the case everywhere, and health centers are good at this stuff because their employees push for it. Health center employees know their communities and they speak up. Organization management adapts to that. So find those places where naloxone education can be given and put those forward to your supervisor. Put those forward to your management as places where that intervention can be done. Anyway, I digress to a certain extent. In addition to other support, he was provided with 7 days worth of medications. Those are his medications for his chronic medical conditions, and signed to CHW for coordination and support. Okay, we went over this. Next slide. Okay, now we're starting. This is new. We were just going over things we've done already. Mr. Stevenson, so the day the appointment starts, Mr. Stevenson is noted to be absent on his 7 day follow-up. The CHW notes that the patient was unreachable for 3 days prior to his appointment by phone or email. He also notes that the patient was not present at his listed address the day prior to his appointment. Okay. there's been stuff happening here. At the address, his sister, the patient's sister, indicated that he had left the property abruptly after an argument with a relative to go live with a friend. The patient's sister also recounted that Mr. Stevenson had been increasingly irritable. She did not observe any indications of opioid relapse, and the patient's sister volunteered that. She was not asked. Remember HIPAA. If there's a question you can ask a relative and it reveals what a diagnosis is, do not do that in the field. That is a HIPAA violation. Um, so she volunteers that information. Sister is very involved in the patient's life. Okay, what do we have going on here? This is a mess. Patient didn't show up. Myself, the person who's going to see him, is finding this out from a CHW's note the day. Um, and we're very concerned because this is, of course, a very sick person who has multiple chronic diseases and was at high risk of relapse. Hmm. It's a lot. It's a lot to deal with, and it takes a moment to think. But Fide, what are your priorities right now? Priorities and reflections. You can always give a reflection as an answer if you don't have a direct answer. Reflections are important. You're muted, Fide.
Sorry about that. Thank you. Well, I'd be concerned mostly about why the patient hasn't been able to be reached for 3 days. And I'd be concerned, I guess, as like a healthcare provider or facilitator, that why he's been missing or not present.
But wait a minute, we assigned him to a CHW.
Mm-hmm.
They just take care of that, right? Why is he not showing
Yeah,
up? You got a CHW, don't they just fix that? Enter like case
yeah,
manager, or like social worker there too. What happened? Why did this? What was missed here? Like, doesn't the social worker or the CHW just make this problem go away?
yeah. Um, but it says like that he left the property. So I think at that point, how can a CHW control that?
Yeah, 100%. It's hard.
Yeah, it's really hard for
It's
somebody to.
hard. It's hard to do this. Like people
Mhm,
disappear. People
mhm.
disappear. Especially like this is a person. What kind of housing would you call this person? Does he live in? Transitional, right? He's
Mhm.
not unhoused, but he's at that layer where, listen, he's been out for 5 days. He's sort of transitionally living for people. He's at extremely high risk for homelessness, extremely high risk, and risk of OUD at the same time. And if you've got both of those risks at the same time, that's a dangerous period in your life. Dangerous period. But this is a complicated patient. What if they don't have a phone? What if they lose their phone? What if I don't know, this is a justice involved individual who got in an argument with a family member. Where else does he go? He goes to a friend's house. Like he follows his networks. And I can say from like having patients like him that like the one, if you're ever doing the calls by yourself to track people down, do that. If you're a clinician, do the calls yourself someday to try to catch someone. It's very difficult. Like it's you have to call relatives sometimes to look to people, and this isn't even just complicated patients like this. Even for a patient that's in the ICU or in the hospital, contacting family is difficult to get to someone. Sometimes it is the only option. Where I think the failure was here is communication between the primary care office and the CHW themselves. I'm just finding out about all these failed attempts here, even though the CHW had documented it, and I'm finding it out on the day when he's at all of these risks. So the CHW put their information in the medical record. There was no one to follow up with it until that day. And there appears not to be good communication between my office and the CHW. So that's a friction point that's very common, and difficult to navigate, because where's the natural intermediary, right? And I'd like to say there are different ways to fix this. First aspect is a perspective. This is an interdisciplinary team. When you're treating any patient, this patient in particular, very interdisciplinary, more interdisciplinary than typical. If you have a patient that's just in for the 6 month Medicaid uh, uh, visit, for example. Interdisciplinary, of course, but does not require time from social work and time from case management like a patient like this. There needs to be a better way to communicate between that and having a time to check the medical record before a visit like this is very important. Um, and what I'd say is, could this have been stopped? Maybe, maybe not, but it's important to look at those systems and say, where could we have communicated better? Could I have looked at this note beforehand? Increasing our control over the internal locus. Remember, there's things you can control and there's things you can't with everything in life, especially with patient care. Have that internal locus as controlled as you can, because that's where you do have the power to control. Okay, next slide, please. Okay. So Mr. Steven is contacted by his social worker with the help of his sister, who is able to locate him and call while in his vicinity. Okay. And this was the same person who was at the door a few slides ago. On the call, the patient noted that he had not overdosed, but that he was angry and experiencing quote unquote mood swings. He also found himself in excuse me, with several close social contacts, including his brother and a close friend who have persisted in using opioids while in his vicinity. Okay. Ref yeah, raise your hand. Go do it.
We have a comment from Mary Clark.
Yeah.
I think it's regarding the previous slide. Could we have his parole officer look for the patient?
There we go. 100%. Involving the parole officer more in that contact is a good way of doing a couple of things there. One, finding out where to find someone. And one, the CHW was assigned by the county, so there may be communication there already, but that seems to not be happening between the primary care center and the parole officer itself. But yes, 100%. 100%. But I will say, even with parole officers involved, people still disappear. And when phones don't work, when addresses are not permanent or transient, it's very difficult to find certain people, especially folks that have very limited housing options. Um, so yes, and agreed. Um, uh, Fide, I thought you were excited to give me an answer, though. Do you have an answer or a thought?
No, wait, give me a second. I need a moment to take a look at this
So
one.
let's throw this to everyone then. This patient is having mood swings and he left where he's living. Why did he do that? Was he just being grumpy? Or did he have a reason? Maybe a good reason, maybe a bad reason. But what encouraged that move and how did that work? His medication, look at that last sentence. Think about him. Mr. Stevenson has had 3 overdoses. Yes, big part of it. He's had three overdoses in the past. He was in prison for 3 years, released, and then he's around like within 5 days he's around opioid use, possibly every day. We don't know how often, but you can see the sister was at the house before, so it's obviously a family dwelling, and not one but two people who are using opioids in front of him. Yes, nailed it. Um, Victoria, could you give us your perspective? Because I think feeling loss of control is an excellent point to sort of poke at a little bit here. Why does he feel loss of control? I love it, but I want to hear it from your words.
Well,
What do
I
you think?
mean, when you're, and it kind of goes back to what you were saying about the gentleman that had been incarcerated for 25 years. You've just recently been released from, let's say, prison for after 3 years. You don't know what's going on. Everybody's trying to tell you what to do, and you have no control. I mean, there's nothing there. You have to get that control back. You have to get that empowerment back. And I think that in this case, there should be some sort of care plan put in place that says, what will you do if you feel this way? Um, because, that independent care plan is always the most important thing to really look at, and it centers a client back to where they might need to be.
Mm. Yeah, you make very good points there. I like the focus on the feeling of agency, and often moving out is all someone can do, and it appears that might have been the situation here. And the loss of control and confusion that you mentioned, it's painted all over his life. If you sort of look deeply in what an individual like Mr. Stevenson's experiencing, he's hearing from us. Oh, you need to take medication. You need to see behavioral health now. Here's all these resources. Let's avoid triggers. Let's create a care plan. Let's coordinate this A, B, and C. Here's a focus group. He's getting resources from his CHW and inputs from us. But when he goes home, someone's using opioids right in front of him. Maybe it's at the kitchen table right in front of him. That contrast is confusing to people, and feeling of loss of control is a big part of what he's going to experience. 100%. Victoria, can you remind us who you serve and how you serve them?
Actually, I work for Altamid in Los Angeles County, and I'm actually a grant writer. But in the past, I have been a director of health education.
Mm. Okay, so we're giving you some keywords here for your next grant. Some buzzwords, and so forth.
That's
Um,
exactly why I'm on the call.
I see. Smart, smart. So I'll ask you something though. The homelessness issue in Los Angeles is much larger than most of the cities that we deal with. It's
Right.
I think the largest in the country. Um, uh, Patients like in the OUD issues there as well are
Mm-hmm.
extremely significant. You can see when you look at the streets of Los Angeles and Seattle and a lot of West Coast cities, when you have individuals that are justice involved, when you have a very aggressive prison system with contrasted with an environment where drugs are very easy to get and are, let's say, inconsistent in their dosing. You have that's why you have a lot of the issues you have in Los Angeles, San Francisco, and Seattle is these epidemics, these health epidemics, homelessness, OUD, is they really conspire together and they strengthen each other in very insidious ways. So good luck with your grant writing.
Thank
Um,
you.
it's a important place to get money. Um, anyway, so who blames him for moving out? We're sitting here, irritated. He didn't show up to his appointment, right? I hate when that happens. I always show up to my appointments. He should show up to his appointments too. No, this is a complicated situation. And we may have missed the ball on a couple of things. It's still not clear here how folks are communicating. And it makes sense that this individual would have left. It also appears that the CHW was doing everything they could, but that this patient still fell through the sort of pasta strainer, so to say. And I will say, you can do everything right every time, and these situations still happen. Do not let it discourage you, and do not let it make you sort of distrust the system that we use. It's always going to happen. It's sort of like using the right medication. You can use the right medication 100% of the time. It's not always going to help. It's just the situation. Our social lives are in our sort of in the way we are embedded into to society in sort of a epidemiological way is just as complicated as our physical body and just as nuanced as well. So keep that in mind. Next slide, please. So at the time, and this is when he moved out. So brother and a friend are using OUD at home. He moves out. At the time, patient also reported intermittent adherence to his medications, including his buprenorphine, which is his medication for OUD, uncontrolled blood pressure, and worsening depressive symptoms. Hmm. He didn't mention his blood glucose. He's obviously not checking it. God knows where that is, right? Of course, these conditions tend to get worse together as stressors are applied. While on the phone, the social worker schedules Mr. Stevenson for an appointment in 3 days and begins providing referrals to social services and support that can support continuity of care. She reviews the results of a recently completed health-related needs screen to guide her. I love health-related needs screens. Let's look at it. Next slide. Okay, cool. So, bottom left, link to resource. This is the WellRx screen. And let's see here. It is the WellRx screen. And it's a template. It's validated. If you click in the bottom left to where it says link to resource, it will take you to the paper that validated and to the to the to the template itself. This is a great screen because it's relatively simple, easy to embed into an EHR or printout, depending on how you want to do it. Especially the embedding is relatively simple. Also, this screen, in contrast to Prepare, is better designed for you to ask your own questions. So. The recommendation for the social needs questionnaires is that health centers, organizations, primary care offices should add questions that they think are appropriate. For example, you live in a rural area, for example, more questions about transportation, perhaps. You live in a area where the unhoused are a large percent of the population. Maybe some more questions about that. Or you add in a question about justice involvement. See where I'm getting here? It's a great scaffolding. It's a great scaffolding that you can adapt. And know your informatics and EHR people well, because this can be embedded fairly easy. That typically requires a different process for each organization, but there is a guy or a girl who is that person who can embed that for you. Get to know that person and sort of the system your organization has for amending EHRs or adding new forms and so forth. And recommend this if you don't do it already. A social needs questionnaire is a great way to catch things early. It can be done at intake, it can be done before the clinical exam. It's fairly quick, and it sharpens your focus. If you know about these issues before you have patient results, you're going to be able to address them better. And in particular, with justice involvement, given what we've seen, that these patients fall through the cracks, that it's very difficult to coordinate resources, and their life challenges are often barriers to care. That's a good place to put that right there. Okay, so there's the fruit to pick. Let's go through the results. Fide, do you want to read them to me? Do you want to read them, tell me what you think? You're muted.
Okay. So far, it seems that the patient in the past 2 months has been skipping meals.
Okay.
Also, he is experiencing homelessness and worried about the future. He also has been having trouble paying for utilities, has also been having trouble with finding or paying for a ride, and doesn't have the need for daycare for
Okay,
his
next
kids.
slide. Continue it on to next slide and then tell me what
Sure.
your thoughts
Yep.
are.
Yep. And then so far he's also unemployed. He also needs help finding a job or a better job and does not need help getting more education, but he's also concerned about someone in his home using drugs. Um, and he also said no for feeling unsafe and no for thinking that anyone is in his home threatening him. I think so far a lot of like what we went over in the description of his case study, this is like a reflection of the things that he's actually experiencing.
Mm-hmm.
For example, um, he is concerned about someone in his home using drugs or alcohol, and we were previously talking about how just within 5 days of him being back into society, he was already being exposed to that. Uh,
Mm-hmm.
so
Mm-hmm.
yeah,
Yeah, well, that well, 100%. This is from this today. This screen is from today. Could we maybe have done this earlier?
absolutely. I
Yeah,
think
I think
I
so.
think if this would have been done earlier, maybe his disappearance from the CHW could have been prevented. Um, Maybe he would have been more
100%.
present to doing his follow-ups.
100%. We did it. It's good, but we should have done it earlier. Yeah, especially with the transportation and the guy missed his appointment and I almost feel kind of silly looking at this because he missed this appointment because of things that he put on the social needs questionnaire and I would have known this if I did this earlier. So, a little demoralizing for me, but what it tells me also is that we need made better systems, and we need to be doing this social needs questionnaire earlier. That's what I think this issue brings up a really important QA QI point. We need to do that earlier, 100%. Question for everyone. Thank you, Fide. A question for everyone else, the group. What pops out? This is social needs questionnaire. We've got a lot of yeses here. What are the priorities? There's a lot. There's a lot here. If you could go back and sort of as we're thinking about that, please put into the chat what are your thoughts about this social needs questionnaire? What is your priority after reading it? And then I will do my read. Okay, let's start with question one. Could you go back a slide, please? Okay. So in the past 2 months, he has eaten smaller meals or skipped meals because he didn't have enough money for food. Yes. Okay. He's like 15 days post-release now. So he's had food insecurity likely since he was released. Um, are you homeless or worried that you might be in the future? Well, we found that out the hard way, didn't we? We found out the hard way because he had to leave a relative's house and go live with a friend. So we know that now in two ways. Um, trouble paying for utilities, gas, electricity, phone. Yes. I mean, we couldn't connect him with him. The CHW literally couldn't get him. He can't afford a phone. Again, we would have known this if we asked earlier. We didn't. We waited. Trouble paying for a ride? Yes. He doesn't have transportation either. See, at his last appointment, the physician, was so focused on his chronic disease and OUD, I missed all this stuff. I didn't
Mhm.
prioritize it, and as a result, the patient didn't show up. Is it a miss? Yes. But it's a miss that's fixable with an interdisciplinary intervention, which is better communication between individuals, better communication between myself and the case manager, social worker, and in this case, the CHW. Housing and provide resources, but you should ask patient what is his priority. Um, Victoria, I got a question for you. I've got this screen here, and I feel like I know what the priority is. Why would I ask the patient? I've got the screen. What is that information going to help? How is that going to help? Victoria, are you able to say? Oh, there you
There
are.
you
Yes, the muting is getting us today. It got me, it got Fide, and it got you.
go. Um, the reason why you should ask the patient is because that's what the patient will follow up on. That's the most important thing. I mean, it's why would you give someone something that they may not think is they would use?
I agree with you, but you know what we think sometimes, Victoria, is we think we know better, don't we?
Yeah, and that's why you ask the patient.
100%. Nailed it. And I'll say this. Uh, it is very easy to look at results, like lab results, screening results, and thank you, Victoria. And to determine what the priorities are for a patient. We often miss the question and the ask, and that is particularly important when we have someone with multiple issues. Because how do we address those? Well, if I feel like I know what the priorities are, we're going to do it in a certain methodology. We're going to take care of A, B, and C according to Dr. Lombardi's plan. But who is the expert on the patient's life? Can anyone tell me who the expert on the patient's life is?
Himself.
The patient is the expert on their life. Yeah, they know stuff you're never gonna know. Not like sorry, you're never gonna beat them in that. They're always gonna be the expert of their life. Um, and their priorities don't just tell you what their focus is. Their priorities tell you, one, do I need to educate the patient more? Because their priorities might be different if they know how serious something is. So they don't know how serious it is now. Also, um, their priorities are going to tell you how to untangle things. It's going to tell you what the biggest stressor is. For example, if they're focusing a lot on housing, or if they're focusing a lot on those cravings, or the transportation is the main thing. The patient will tell you the priority, and luckily, we have colleagues in case management, social work, community health that do that for a living. It's missed in the exam room sometimes. Ask the question. Know the priorities as the patient describes them. You may not always agree, but their perspective will always guide you. Next slide, please. And next slide. Okay, so we talked about this a little bit, but let's see, make sure we're being comprehensive here. Unmet needs of preventing Mrs. Stevenson from his appointments. Can we go back again? Sorry, go back to. Let's just do our full triage here. It's 42-year-old male, 10 days post-release, food insecurity, worried about homelessness, worried about utilities, worried about ride. So, and he does not have children. Next slide. Unemployed, does not have regular income, needs help finding a job. This is someone who needs to have a longitudinal relationship with the CHW. We have done that. That is happening. But the things that I'm going to want to ask as a clinician are different than the ones that the social worker or case manager is going to want to ask. And I am really looking at this abuse and safety. So he does feel safe. Sorry, he does not feel safe, but someone is not abusing you. That's the first thing that I'm going to focus on is that. Um, why is that patient feeling unsafe? You know, what do you guys think? Because he's not saying that someone's threatening or abusing him, but what about his story says unsafe? Why is he feeling unsafe?
Because he's around people that are using and he's got nowhere to go.
100%. This man has had three overdoses. If you've almost died three times, one of them he was in the ICU. When he sees that those opioids, he hasn't used anything from what he's told us, and we've got no reason to think that he's lying to us. That's terrifying. Him sitting at that table and someone pulling out a needle or pulling out a spoon, pulling out a pill, pulling out foil. There's a whole ritual to drug use that people get embedded in over years, and it perpetuates it. It makes it feel safe. After you've had an overdose, uh, uh, 3 years in prison may have been related to drugs. The timing certainly seems like they were at least in a cursory way involved. That's going to scare the heck out of him. And it's going to make him feel very unsafe. What do people feel when they feel unsafe? They feel like they want to run away. If I was Mr. Stevenson, I would want to get out of that house too. Unfortunately, where do people land? He's fortunate that he had a friend's house here, but these individuals end up being unhoused a lot because they want to run away from something that scares them, like if someone putting drugs on the table is like someone pointing a gun at them. Right? Like that's how scary it is for folks. And he leaves. A lot of times people bounce right back to the street. And where's another great place to get exposed to opioids? When you're unhoused, right? That's where the drugs are sold. That's where they're consumed in many cases, depending on where he is, of course. But he put himself from an unsafe place and could potentially run away to another unsafe place. So very serious, very, very serious stuff. Next slide, please. And we can go after the question. Okay. Oh, sorry. Look, can I look at the last one for a second? I think I may have missed a piece. Go back one slide. Welcome to musical slides with Dr. Lombardi. Unmet needs, so he's missing his point. Yeah, okay. It's key the transportation, the housing, the stress, and the priority. The priority. How high is the priority for him, this appointment? Low, because frankly, he's worried about eating, worried about having a place to sleep, and being constantly exposed to something that scares him to death. We became less of a priority. Don't take it personally. Create infrastructure to make yourself a priority by contacting the patient, by showing up, by calling the relative, putting that work in. It's necessary to save a life in this circumstance. Guardrails. So putting guardrails on a dangerous highway. Next slide, please. And next slide. So I have two theoretical paths for you here. And our story today is more in the structured path part. It's we're working on being structured. At Fide and I's hypothetical health center, we don't have a lot of experience with justice involved individuals. There's no local federal prison. Like they're not a regular part of the population. We just have Mr. Stevenson here, and maybe we've seen one or two of these individuals in the past. We don't have advanced systems. We're using our experience with him to QA, QI ourselves to victory and have better systems. And remember, that's never finished. That's a job that's never done. You're always making your systems better because you're always adapting. Your health center is like an organism like in the wild, adapting to the environment. And you are the brain cell or muscle cell making that happen in that organization. Adapt and survive. So we get better at making our systems by looking at patients that require a lot of resources and asking ourselves, how do we make this easier? So let's look at the structured path and the unstructured path and see where we're going here. Our unstructured follow-up path is let's treat this guy like he's just another patient that just walks in for an appointment, right? What's going to happen? He's going to get lost to follow-up. He is very likely to show up at the emergency room. One, because he needs primary care and he doesn't, we're being unstructured. We're not following up with him. Maybe he goes there instead of here. He doesn't have insurance. He's not thinking of that. He's not thinking of the cost right now. He's not worried about the collections bill from the emergency room. He's worried about day to day, moment to moment. So very likely to show up at the emergency room. Increased risk of overdose. He's exposed to it and is not structured in his primary care use. Dangerous. Post-release period, most dangerous time to be in America in anyone's shoes. That's it. Um, uh, and poor medication compliance. No way to enforce medication use. And when I say enforce, I mean it lightly. Um, Systems for success are not there. Structured follow-up path, we have flexible scheduling. You don't show up, that's fine. That's fine. We got you on the phone. Let's give you an appointment in 3 days. Be flexible. Prioritize these patients for slots when they're available and you can get them in. Better retention and care. We make things easy for the patient to show up. There's a lot of friction in getting primary care, in getting care in America. You don't just show up, like you got to get insurance, you got to show up, you got to sign your papers. It's very confusing to your lay person. Imagine if you've been in prison for 3 years, longer. It's all foreign. It's like going to another country. But the easier you make it for them, the easier you make that transition. Um, and what happens when you do all of these at once? It's statistical. You reduce risk trajectory. Every one of those little program moves, every one of those um, extra emails, those calls to sisters improves that risk trajectory and makes the range of possibilities that Mr. Stevens is going to experience better. Everyone, they all conspire together. We talk a lot about chronic disease. If you have diabetes and hypertension and substance abuse, these conditions all conspire to make things so difficult. How you feel, how much money you make, how much. We talk about that a lot, but we don't talk about the systemic effects of positive things quite as much. And when you are intervening in a detailed way, with multiple programs, with things for transportation, things for making sure he has insurance, and so forth. It's the same complex contextual relationship, but it is a positive one. You're doing the same thing, the same mechanism as something like a chronic disease, but you're doing it positively. That's I don't know. Feels like we're taking the enemy's weapons and using them against them. So I guess I digress to a certain extent here. What I'm trying to get across is that social support is contextual, and it's very complicated. But you can trust that each of those little steps that you make to remind a patient, to talk to them, to institute a system, make sure that you get things early with an early social needs questionnaire. These don't just make things better in a sort of like A equals B way. They change the trajectory. They change the whole scope of reality that this patient can reasonably expect from a statistical perspective. It just makes things better. Anyway, next slide. And sort of some talks about the post-release period. By initiating prevention early, you provide critical support, plain and simple. The death risk rate of mortality and morbidity actually is highest in the 2 weeks post-release, and that is not a small difference. 10 to 40 times. 10 to 40 times. Think of anything that's 10 to 40 times as large as anything. I don't know. That's like comparing the economy of New Jersey to the whole United States. That's like the magnitude here is so monumentous that like numbers don't really get it across. A 10 to 40 times greater risk of mortality and morbidity is a different world. It is a different world. Every little thing you do ticks that down. And it really genuinely changes reality for these patients through changing their trajectory. Trajectory management. Next slide. That's where you heard it first. Trajectory management here. Uh, and sort of just like a cascade framework. Identify, engage, treat, retain. That's how you do it. Identify with the social needs questionnaire. Engage the patient about what they put down. Treat their issues, and your retention will go up. It's mathematical. And you know what? I love math. Let's talk some more about math. Hope you guys like math too. Next slide. So this is a logical chain. If you don't talk to the patient, he will not show up. If you don't do a screen, you don't get that information. So let's just break this down mathematically. So, say we have a system, and in our system, 60% of the time we identify the patient, 80% of the time we follow up and engage them, and 50% of the time we treat that issue. If all of those steps logically follow, as they do, then all of our errors, they accumulate. And with that patient, our chances of getting it right are 24%. Does 24% sound good to you, Fide?
It sounds, no, that's so
It's
good.
not good. It's not good for
Mm.
anything. Don't get a 24 on anything. Your biology test, you got a 24. Congratulations. No, it's not good. This is averaging these to a certain extent, but these are they logically follow. So if you lose, sorry, this is not an average. It is a logical progression. So if you only identify 40 of the patients, 40% of the patients that have this, then you're only going to be able to engage the ones you identify. So the group gets smaller and smaller and smaller and smaller as you miss people. Let's take another simulation and say we're just a little bit better. See how it changes things. We identify 95% of the patients. We put a good screener in there. We engage 92% of them. Not perfect, but that's pretty good. And we treat 93. That gets us to 81% for 24%. Is that a big difference? Yes. What I'm trying to get across here and like in different languages is that small differences in each step of this continuum of care, they add up together in a way that is more severe than you might think it is. So if you get better at one of these steps, you make all the downstream steps more effective and you get your number higher. And if you go from a 0.24 to 0.81, that's half a patient, if you're seeing one person. If you're seeing a population, that's lots of people. And that's more revenue. That's a healthier value-based care dynamic and a healthier patient. A healthier community. What more could you, oh, bye, Victoria. Thank you for joining us today. Um, what more could you want? What more could you want? That's how you fix it. Well-designed systems and engineering each aspects of that continuum of care. Okay. What do you think, Fide? Did I get my point across?
Absolutely.
Okay, cool. Next slide. Okay, and non-medical support and retention. We've gone through this. Some things to emphasize. One, the CHW doesn't trust me. He trusts the CHW. Sorry, the patient doesn't trust me. He trusts the CHW. And the reason is the CHW is a master of communication, the social worker, the case manager, the individual that speaks the patient's language and knows how to say the right things to them at the right time to get them to understand what the issue is. That is hard for me. There are professionals that do that for a living. Lean on them, use them, collaborate with them, speak to them. And the emphasizing the importance of trust, building that trust. Not to say that clinicians can be very good at that. We can get good at that. But the best way to get good at something is to have a colleague that does it for a living. Use the phone, jump on, talk to them, understand their perspective, put them at the table at the interdisciplinary meetings, at the board meetings, at the advisor meetings. Put them there. You will learn things that will make you better, and that goes with for everyone for their respective different islands of the professional, the continuity of care archipelago. Next slide, please. Um, yeah, value-based care is important. It's our life. If you work at a health center, the largest percent of the budget probably, or a large part of it probably comes from Medicaid. If your patients are using Medicare, Medicaid, private insurance, all those systems, the value-based care dynamics penalize ED use. So you might not know it's affecting your health center if a patient uses an EED, but it is. So make them healthier, make your institution financially healthier. Next slide. And that's it. Questions? And it just started getting sunny out here in Virginia. I hope it's sunny there wherever you are as well.
Thank you.
Is it sunny? Is it sunny in Woodbridge? It's sunny in Loudoun County.
Yes, it's very sunny over here.
Jamoke,
Only
is it sunny in Montgomery County up in Maryland? It must not be.
I think I lost you. I didn't hear. Say
Is
that
it
again.
sunny where you are in Montgomery County?
Yes, it actually just
Okay, cool.
take a
Well, let's
walk.
all go and enjoy a little bit of that and
yep,
think about care continuity. That's all I have for you today.
definitely. Definitely. Thank you so much,
Thank you.
Kevin.
Kevin.
Thank you, everybody. And if we don't have any questions to be asked at the moment, you can always follow up with us via email. But just a reminder to please complete our post-evaluation, and we'll see you next week at the same time. And thank you, everybody. Have a great day.